interesting topic. Very fine. You tell me, Amit, when to take. Is Ashita online?
Ashita is joining in some time. She should be joining. Yes.
So tell me when to start. I'll just make a brief beginning introduction. Then I'll hand it over to Priya and then to
Yes.
Ashita.
Yeah.
And then it will begin.
At 8 o'clock, I'll play this Saraswati Vandana, and then you can.
Absolutely. Absolutely.
Now, Dr. Vimal is to join, still.
Yeah, I'm just messaging him, sir.
And Christopher also.
सरस्वती नमस्तुभ्यम्
Amit, do I start?
So just give me 5 seconds.
सरस्वती नमस्तुभ्यम् वरदे कामरूपिणी विद्यारम्भं करिष्यामि सिद्धिर्भवतु मे सदा पद्मपत्रविशालाक्षी पद्मकेसरवर्णिनी नित्यं पद्मालयां देवी सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा
Thank you, Amit. Good evening, all. Welcome on this last in the series for advanced topics webinar, which has been solely being responsible by to be held by Priya. Priya, you have conducted a wonderful 11 sessions of webinar on advanced MRI topic. Is good work by you and your team. I thank you for that. Today's topic is on CMR in valvular disease by my very good friend, a renowned cardiologist, a full-time consultant with Jupiter Hospital, who is going to speak for the next 45 minutes on this particular topic. He's also going to moderate on the same session, which has been spoken by Saul Marison from UK in the November 23rd, 24th annual conference by IACI. All these 11 lectures, webinars will be bundled up and be available to be seen when this link will be uploaded on the webinar. Amit, we should bundle all these things and it will be available on the website in the next coming 2 weeks. I now, before hand it over to Priya, Nitin, can you just briefly tell us the growth of Dr. Priya in cardiac imaging, particularly CMR, in such a short time where she has done such a wonderful job? Can you just spare 30 seconds and tell us how has she matured out in front of your eyes in Jupiter?
You are giving me a very short time. 30 seconds is not a time that I can speak about her. Okay, otherwise I can talk for 30 minutes. Okay, Now the thing is, she's very dedicated and she's always ready to learn new things. She interacts with the clinicians very well, so that has given her another dimension that she can interpret the cardiac MRI with the with the eyes of a clinician also. And she reads the current literature regularly, and I think she has mastered from basics to the advanced, and she remains very contemporary with the developments in MRI. So I wish her luck. I think her she has not yet hit the ceiling. She's going to go on growing. Best luck.
Thank you. Thank you for those kind words. Priya, can you come on screen, guys, and lead this
Yes.
program?
Yeah. Thank you very much, sir, for this kind words. And I must admit that all my clinical training and learning in cardiac MR is thanks to you. And without any further delay, we, as Dr. Telkar said, this was the ISCI webinar series, what we started after the last year annual conference. Excellent topics, and all the faculty members, I really thank you from bottom of my heart that everyone has agreed and they have given really nice talks. And this will be like a treasure which will be there on the ISCI website. Few upcoming ISCI activities which will include series related to physics. Probably we'll be starting it from December after the annual meeting. Dr. Richa Kothari and Dr. Pudiawan will be the main in charge who will take ahead. And for all the beginners and for all the learners, this will be very good. So please do not miss it. There will be also monthly case discussion series. Dr. Rajesh Kannan will be in charge. And even monthly journal club meeting will be there, which Dr. Johan Christopher will be taking ahead. So there are more and more activities. So be stay tuned to the ISCI websites and all the WhatsApp groups. But most important event is the upcoming annual meeting, which is there on the 23rd and 24th October, where so many renowned international faculties are going to give excellent topics like evidence changing practice, COVID myocarditis, MINOCA. There are joint symposium with SKI and SCMR, and even for this arrhythmiogenic substrate. And then we too have a talk on the valvular heart disease, about mitral valve and aortic valve imaging. And there are more and more exciting talks and more prizes, etc. So this 2 days events is really worth attending. Do not miss that. Now we, without any delay, we start today's session. It is going to be on cardiac MR in valvular heart disease. And as a imager in cardiothoracic imaging, it is important to know the clinical aspects, and which probably Dr. Burkule will share with us, that which tool to use, when to use, and how to use. Over to you, sir.
Thank you, Priya. I think the web series was started with strain imaging, and I think we are ending with valvular heart disease.
Yes, yes, sir.
And interestingly, I was involved with both the the
Yes.
start and the finish.
Yes, sir.
Thanks ISCI for that. This is a very elite group of imagers. I will share my experience with the valvular heart disease. Can you just allow me to share the screen? Yeah, I think someone will have to enable my share.
Yes, sir. Just a minute. Amit?
Sir, it is enabled for you.
Yeah, now enabled, yeah. So my screen is visible, isn't it? Yeah. And the screen is visible now, Priya?
Yes, sir. Yeah. Yes, sir.
Yeah, and the quality of audio is okay, fine. So friends, let us go into the depths of use of cardiac MRI in valvular heart disease. Interestingly, CMR is a very powerful tool for the valvular heart disease. It's very versatile, and I think the cardiology community should get well versed with this utility of cardiac MRI. If we see the 2017 American Society of Echocardiography guidelines, you will see that they are developed in collaboration with Society of Cardiovascular Magnetic Resonance. And that shows the importance of cardiac MRI as a highly complementary role for the assessment of valvular regurgitation. So what we'll do is we'll go from basics to the advanced, and the cardiac MRI for the valvular heart disease got revolutionized because of the phase contrast imaging. And all of you are imagers, so I don't have to really go through the basics, as we know that if there is a stationary spin like shown here in blue and another spin which is moving, and if we expose them to a bipolar gradient of equal magnitude, then generally the one which is a stationary spin after exposure to the bipolar gradient will come back to its original phase, while the one which is moving, shown by the red arrow, one it gets exposed to this bipolar gradient at various time points, it will either achieve some phase ahead or will lose a phase behind its original phase location. So here we can see it has a lag behind by minus 39 degrees. And the studies have shown that the amount of phase gain or phase loss is directly proportional to the velocity of the moving spin. And the only moving spin in the cardiac imaging is obviously the blood. However, we have to realize that when there is a turbulence, then this linear relation goes for a toss. And this is very important for the stenotic lesions. Then there are certain conventions to show the direction of the flow, and the flow which is towards the head is generally shown with the white shades. The flow which is going towards the leg is shown as black or darker gray. The blood flow towards the right is shown black, and the blood flow towards the left is shown white. So something which is going towards the brain and which is going to the left side of the body is conventionally shown by the white scale. Next thing is the quantitative analysis. What the phase imaging does is that for every phase during the RR cycle, it measures the cross-sectional area of your region of interest of the vessel, and then measures the velocity of each of these pixels, and then averages it out. The velocity into the area gives you the flow. So that instantaneous flow is mapped over the time scale throughout the RR interval, and you get the map like this. And then the area under this curve will give you the total forward flow or the total backward flow integrated over time for that particular RR bit. So this is how the flow is calculated, and that leads to giving you a forward flow volume, regurgitation volume, and then it gives you the regurgitation fraction also. So regurgitation fraction is what? At numerator you have got a regurgitation volume, and at the denominator you have got the forward flow across that wall. Now the regurgitation fraction is a very important parameter because the regurgitation volume can get affected by the preload and afterload and the cardiac contractility. However, in the regurgitation fraction, both the numerator and denominator get equally affected. So it remains unchanged, and that is why it is important. And so also we can get stroke volumes, cardiac index, we can get the neck forward flow too. And also some peak and mean velocities can give you the gradients. Now the thing is, we know that the positive phase in a particular direction that the spins achieve is related to the velocity information. So as in a particular direction, when there is a positive phase gain, we show it by more and more shades of white, and until it becomes completely white. So 180 degrees phase change in one direction is shown by the maximum velocity that we have decided for that particular sequence. So that is the Nyquist limit, so also called as the velocity encoding parameter. So here it is 200 centimeters. While the flow in the opposite direction is the negative phase that you get, which is shown by the darker shades of gray till black. Towards minus 180 degrees. So it is a minus 200 centimeter per second in opposite direction is being shown in this particular image. However, if the flow exceeds in either direction above positive 200 centimeter or negative minus 200 centimeters, these grayscales will wrap around and that will lead to aliasing. So your white flow will suddenly start showing black pixels, or the black flow will suddenly start showing you the white pixels. And this particular velocity encoding is decided by the strength of this bipolar magnetic gradient that you are giving. So when you give a very strong bipolar gradient, you have a lower velocity encoding. So here the 0 to 50 centimeters of velocities are spread over a phase change from 0 to 180 degrees. So every small degree change is assigned a smaller velocity. So there is a more precision when your Wenck setting is low. However, when the velocity exceeds, you will land up with aliasing. While when you use a lesser magnitude of bipolar gradient, here it is to you will get a velocity encoding of say 200 centimeters, then 0 to 180 degree phase change is spread over for 0 to 200 centimeters. So for every degree, you have a higher velocity which is assigned. So that is why there is a less precision here, because few degrees here and there of miscalculation can lead to major changes in the flow. So a higher Wenck gives avoids the aliasing, but then instills inaccuracies of the flow measurements. So most important thing is that you have to choose a velocity encoding just high enough, and actually your echo Doppler can give you the velocity across that particular LVOT or RVOT or aortic wall and pulmonary wall, and you can choose your velocity encoding setting just above that to avoid aliasing, but should not be too high to instill uncertainty or low precision. Then comes the problem of the partial volume effect. Now, when you are having this region of interest, if you have got smaller pixels, that means higher resolution, then you will have less amount of partial volume effect at the boundaries of this. When you have got larger pixels, the larger pixels at the boundary will average the velocity from the vessel and also from the peripheral tissue, the noise around the peripheral tissue, and then that will introduce the inaccuracies. So as the pixels per vessel keep on reducing, the flow errors keep on rising. So the best is that you have to have somewhere between 10 to 18 pixels inside this vessel wall to reduce this partial voluming effect and improve your accuracy. Then the imaging plane has to be through plane, and it has to be perfectly perpendicular to the flow, and that actually amounts to change in the velocity that is measured, and that can cause the inaccuracies in the peak gradients. But it hardly makes much difference if you are measuring volume flow across that particular cross section. So even if it slightly tilts, it won't make much difference for the volume, but it will make a big difference for the peak velocities, which is 4v square. Then there are certain planning issues, and these are obviously your flow should be at the isocenter of the magnet. 6 millimeter slice thickness or little more will give you better signal to noise ratio. You should be perfectly perpendicular to the flow or the jet, and that can help you. And generally your in-plane images will tell you where to plan for that particular jet, whether you are perfectly at vena contracta or not. Your spatial resolution should be at least less than 1.2 by 1.2. Your temporal resolution is something very important. You should have at least 25 to 40 milliseconds. Higher is better, because if there are when there are flows across the outflows which are laminar, it really doesn't matter even if the resolution is slightly towards 40 milliseconds. But when there are dynamically changing gradients across these outflows, then if your temporal resolution is less, then you will miss some of those peaks of velocities, and that will introduce error. So this is very important, that you should have at least more than 20 frames per RR interval. Because remember, the resolution of Doppler is 10 times higher. It is as low as 2 to 5 milliseconds. So that is why getting the dynamic velocity changes across a dynamic LVOTO or critical AS is much better with Doppler than the current MRI techniques. Then you should have at least 8 to 16 voxels in your region of interest. at least more than 14 to avoid the partial voluming. And your wing sitting, go by whatever the echo shows of the Doppler flow, keep it slightly higher than that, because these flows can change with the patient's physiological status also. With this, we also know that the quantitative imaging, remember most of these phase imaging cross sections are slightly bigger than the magnitude images. So you should trace the boundary of the vessel wall, slightly outer border of the vessel wall, but you should not introduce any pixels outside the vessel wall, so that there is no error. But you should not be well inside the vessel wall, because you will lose some pixel data at the periphery that can introduce error in the flow measurements. A correct ROI for every phase that you are having, and see that all the pixels are included. Sometimes you can just just correct the baseline to avoid the aliasing in either direction. Now with this, we'll also have certain imaging issues related to our SSFP images or the GRE images, which are in plane, which show you the gradients, like which show you the flows, the jets. Like this, these are the in-plane images showing an aortic regurgitation jet, or these are the images which are showing the mitral stenosis jet. These are the images which are showing mitral regurgitation. So you know exactly where is the vena contracta, and you can plan accordingly for a through plane imaging. So these, especially the spoiled GRE sequences, are better than the SSFPs to look into these jets. So in plane images are for qualitative analysis and for planning the quantitative planes of imaging. Now let us go into the nitty-gritties of how to quantify regurgitation. So let us start with the tricuspid regurgitation. And let me tell you that the right-sided wall regurgitations is the strength of MRI. The TR and PR volumetric measurements is the strength of CMR. So let us look at at this particular case. Now, before we go into the case, let us look how we measure the tricuspid regurgitation. So this is the tricuspid regurgitation. So the first thing is that you measure, you take a good short axis stack of your RV and get the volumetric data of the RV. So you get the total RV stroke volume. Remember, this stroke volume is going to consist of the TR volume and also the forward volume. So we have a phase contrast forward flow measured at the pulmonary trunk, at the base of the pulmonary trunk or the pulmonary root. And if you subtract these two, you will get the TR volume. And this is a very nicely reproducible measure of TR volume. And echo has certain challenges for the TR volume measurements. So this is the most preferred method for TR volume measurements, for RV stroke volume minus the PA forward flow. And you get the regurgitation fraction, where numerator is the regurgitation volume divided by the total stroke volume of the RV. Now, the beauty of MRI is that you have got certain internal cross checks or internal quality controls. So you have got two other methods which are not preferred ones, but which you can use them for the inter-quality control. So if you don't have normal left-sided valves, then you can have your LV volumetric data, LV stroke, RV stroke volume, and also LV stroke volume. And obviously the RV stroke volume is going to be bigger because of the TR. So you subtract the two to get the regurgitation volume, provided you don't have an MR or AR. So this works as an internal quality control. So also, instead of using the PA forward flow, you can always use the aortic forward flow also to subtract from the RV stroke volume. So this is why we have got two more ways to have a quality control. Now this is a 19-year-old male with a primary TR because of a flail tricuspid leaflet, which was traumatic. Now these are the perfect cases for the follow of looking at the TR regurgitation volume and also to have the RV ejection fraction. So this is how you will have the right ventricular tract, have as many RV stack as you can have without any intervening gap, have the perfectly planimetered RV cross-sectional areas and get the RV volume. So now in this patient, we have the RV end diastolic volume, which is 210, and RV stroke volume of 108 ml. while the LV stroke volume is 55 ml, which is in a physiological range, while RV is supranormal. And then we'll look at these patients, the phase contrast for the pulmonary flow, and you get a forward pulmonary flow, which is 53 ml. You have to subtract this 53 ml from the total RV stroke volume, and you get a RV regurgitant volume of 55 ml. And then the regurgitant fraction, it will be the regurgitant volume at numerator, and at the denominator, total RV stroke volume. And that gives you a 50% regurgitant fraction, which is very, very high and severe by all the ASC criteria. Then there are certain other ways also. If you plan your imaging plane well, then you can also at end systole can actually look at the tricuspid regurgitation, the tricuspid wall, and can actually planimeter this effective regurgitant orifice, actually the anatomical effective regurgitant orifice, which can also help you to know whether your measurements are right or not. Now let us look at this another patient with a secondary tricuspid regurgitation. Now this patient has got a St. Jude mitral prosthesis and has a secondary TR. Now these patients, obviously the GRE images will not be that great because of the magnetic susceptibility related to the prosthetic wall there, but still you get good diagnostic quality images. And the first thing that you notice is that with every systole, on this spoiled GR image, you can see that the IVC is showing a reverse flow. That itself tells you that in systole, the TR is so voluminous that there is a regurgitation in the inferior vena cava. And that means the TR has to be voluminous. Then we have this a short axis stack of the RV, and you have got the RV stroke volume, it is 104. You have got the RV ejection fraction, and the LV stroke volume is 77 ml here. You can have your pulmonary flow, you can properly planimeter the RV in diastole and systole. Each phase, for each slice, you can go through very meticulously, because we always say that the MR is a gold standard for volume, but it is only gold standard only when you are very, very meticulous. Every slice, you have to go through every phase, seeing that you have properly planimetered it or not. Then only we can boast that this is a gold standard. And then we have his pulmonary forward flow measured here, which is 57 ml. We have to subtract it from the RV stroke volume, which was 104, and from 104 minus 57, we get 47, and we get a regurgitation fraction of 45% for this secondary tricuspid regurgitation. The same thing is true for TR. Remember, TR and PR are a strength of cardiac MRI, because there are certain imaging challenges with transthoracic echocardiography there, especially for the PR, not so much for TR. Now, suppose this is the pulmonary regurgitation. Now the beauty of MR is that for PR and for AR, it's very a cakewalk. It is very simple, because you have to just plan a phase contrast image at the root of these vessels. And in one image, you get both forward flow and a regurgitant volume, and you really don't have to do further calculations. And that makes the things very, very easy. So the preferred method is only a PC image at the pulmonary root, and you get the forward flow and the backward flow. The backward flow is a PR regurgitant volume. If you divide it by the positive flow, you get the regurgitant fraction. It is that simple. And also you have got internal checks. Then that internal checks are simple, that you get the forward flow, and also you get an aortic forward flow, and just subtract the PA forward flow from the aortic forward flow, provided there is no AR there, and that can act as your internal quality control. And so also you can just subtract the RV stroke volume from LV stroke volume from your volumetric data, provided there is no left-sided lesions, and that can also give a second internal quality checkup. So here is an 11-year-old boy post-op repair. Now these are the ones where there are a lot of challenges for us to buy echocardiography because of a poor echo windows, and you can't keep on doing transesophageals for these patients. Now here, though we have sternal sutures and certain challenges with the magnetic susceptibility artifacts, but still you get good quality images. And then just looking qualitatively in those in-plane images, you can see that there is a large PR jet which is showing the dephasing jet going all the way down there till the RV base. And then you have this mitral flow, this pulmonary flow here on a phase contrast image. You have got a forward 77 ml shown by this blue graph. And then you have got a regurgitant volume of 39 ml. So you have a regurgitant fraction, which is almost 50%. And then you have got a forward flow of 38 ml. But very interestingly, in the same patient, you can also plan across a right pulmonary artery. And then you can have a forward flow as is shown by this blue graph, this green graph. You have a forward flow of 54 ml and a regurgitant volume of 25 ml in just the right pulmonary artery. And you have a regurgitant fraction which is almost matching there. It is almost going to towards 50%. And you have net forward flow of 29 ml. And if you can have even a plane across the LPA, and you have a forward flow there of 20 ml, a regurgitant fraction of 38% there, and a net forward flow of 13 ml. If you add just the RPA plus LPA, which is coming to something around 42 ml, and we got something like 38 ml by our pulmonary artery imaging. So we are much in within those 4 to 5 mLs here and there, and we know that we are having a good internal quality control, especially having an isolated RPA and LPA flow, both forward and backward, is something that only the MRI PC images can give. Then we can have the RV stroke volume in this patient and the RV ejection fraction to take the further decisions. So in the PR and TR, it is better that PR is by the phase contrast imaging. You get much accurate quantification. For a TR, use the combination of the volumetric image of the RV, volumetric data from the RV by this short axis stack, and subtract the PA forward flow by the PC imaging. So you are using a hybrid method. And both these are quite accurate, reproducible. They are almost like gold standard, because that is the only thing probably we have for the right-sided valvular lesions to go more towards the precision for especially a long-term follow. Then mitral regurgitation. So we'll start with a case, a 46-year-old lady. She's a dilated cardiomyopathy. She got admitted with shortness of breath and an acute pulmonary edema. Now, this is her echo, and you can see that there is actually a secondary mitral regurgitation. But remember, in dilated cardiomyopathy, secondary mitral regurgitation creates lots of problems, and accurate quantification is very important, and their thresholds for severity are much lower than the primary mitral regurgitations that we see day in, day out, which are because of the primary mitral wall pathologies. So quantifying secondary mitral regurgitation is very important. Now, MR, we have got lots of echocardiographic tools that we look at the morphology, we look at the qualitative jet areas and the CW densities, and then we have got a certain ones which are semi-quantitative, and then we have got some quantitative where we look at the effective regurgitant orifice, regurgitant volume, and regurgitation fractions. Now, these are the ones which is called as the proximal isovelocity surface area, which is used by color Doppler, and you get the regurgitant orifice and the regurgitant volume through this, and then you get a CW across it, and from that you get a regurgitant volume and the regurgitant fraction. And these are that way quite reproducible if you do them very, very precisely. Then there are some certain 3D data sets that you can acquire, and you can cut the 3D data set accurately by positioning your planes, and then you can actually planimeter the effective regurgitant orifice also by the vena contracta method on the 3D color Doppler methods. MRI has actually a very simple way to look at the mitral regurgitation. So this is a mitral regurgitation. So what you do is that you have the LV volumetric data. From that, you have a stack of end diastolic volumes and end systolic volume measured from the LV short axis stack. And from that LV stroke volume, you just subtract the aortic forward flow, which you measure by the phase contrast imaging. And this is the most preferred method, and it has got a very good reproducibility. And this is the one where you can get regurgitant fraction, where the numerator is the regurgitant volume divided by the total LV stroke volume. This is the most preferred method. And as I told you, for internal quality checkup, if your right-sided valves are fine, then you take the RV stroke volume, take the LV stroke volume, just subtract the LV stroke volume and RV stroke volume, and you can have an internal quality checkup. Or instead of the forward aortic flow, you can just have the pulmonary forward flow, which you can subtract from the LV stroke volume. So you have got two ways for the quality control or the internal checkups. So now this is the same patient where these are the SSFP images with the MR jet. You can see with the eccentric jet MR, and then this is a short axis stack here, and we have got a LV stroke volume of 58 ml here. Now we have got this forward flow by the phase contrast image, and we have got an aortic forward flow of around 28 to 29 ml. If we subtract the two, the LV total stroke volume minus the aortic forward flow, we get a rigid volume of 29 ml. Now remember here 29 ml looks quite small amount, but in a secondary MR, it taxes the ventricle too much because already the LV is depressed and a part of its stroke volume is going into the left atrium. So even this 30 ml is a big burden for the LV in a secondary mitral regurgitation. So that is reflected in the regurgitation fraction. So you can see the regurgitation fraction is 50% despite the regurgitation volume was just 29 ml. And so also we can do the same thing by quality control by looking at the LV stroke volume and the RV stroke volume in this patient, and where we subtract the two and we get 28 ml, which are very, very close to what we got by the preferred method of LV stroke volume minus the phase contrast aortic forward flow. And we get a regurgitation fraction, which is also very close, telling you that you have already have an internal quality check for this particular patient. So for the same patient, when I put his Doppler methods of PISA or quantitative Doppler versus the CMR phase contrast versus CMR LV stroke volume, we have got a great degree of agreement in the regurgitation fractions and regurgitation volume. But the thing is not so always. And that is what I want to bring to your notice in my subsequent slices. Then there are ways to look at the mitral valve scallops. And you can plan your long axis either in these tilted ways or parallel or by multiple parallel imaging planes. And then you can cut through the A1P1, A2P2 and A3P3. Generally, when you are slightly angulating them, actually you get much better idea about the leaflets and also which one is actually causing the regurgitation. But however, their 3DT is far superior because it gives you real-time images like this, and that is why I think we need not have to go through all those intricacies of taking long axis views on the MRI. But let me tell you about some important thing about the MR quantification. And this is a study, a very interesting study by Uretsky and colleague. I think last almost 12-15 years, they had a series of papers from 2008 till 2020 comparing the echo and MR for the mitral regurgitation quantification. And this was one of their largest study where they had a head-to-head comparison of echo and MRI. And only of these patients, the 38 patients had an isolated MVR, and 26, they had additional information of MRI after the surgery, 5 to 7 months after the surgery. And then they correlated the post-surgical LV remodeling with the MR severity judged by both CMR and echo. And they have got some certain very interesting findings. Now, if you look at these MRI readers, the MRI reader 1 versus MRI reader 2 for quantifying the mitral regurgitation severity, you find that there is a very good concurrence. If you look at the moderate MR, now this is the concurrence at 25 patients. So the reader 2, out of which 27 patients, he has a concurrence with 25, while the other reader, out of his 31 patients, he has got a concurrence with the other reader for 25. And so also the concurrence for the severe MR is quite good between the two readers. And interestingly, these two readers were at completely different level of their training. One of them was just a beginner in the MRI, while the other one was a consultant. Now these are the two echo readers, and interestingly, these two echo readers were one of those luminaries in the echocardiography field. And interestingly, the concurrence is not that great. If you look at the moderate mitral regurgitation, it was only 14 out of 34 in the echo reader 1 versus 14 out of 30 in echo reader 2 that there was a concurrence. The concurrence was okay at severity of mitral regurgitation, but for moderate and mild, the concurrence was not that great. Though these two echocardiographers were at much higher level in their profession. Then there was another interesting thing that for the same group of patients, echo identified almost severe MR in half of these patients, while MRI identified mild MR in almost half of the patients. So that was very interesting. So there was a lot of controversy, especially at the severity of range. And then this is the head-to-head comparison of the classification of all these 100 patients between mild, moderate, severe by the MRI and the echo. And if you look at the concurrence for the severity of mitral regurgitation, then what was diagnosed by the echo Doppler as a severe, it was virtually split into one-third, one-third, one-third by the MRI. So there was a lot of controversy at this mild range of mitral regurgitation, and that could explain the reverse remodeling after the surgery. However, there was a very small group of patients, like around 30-35, whose MRI was available after the surgery. However, the cardiac MRI regurgitant volume had got a very good linear relationship with regression of LV end diastolic volume. So at least telling us that probably the severity by the MRI in the severe mitral regurgitation was probably accurate, because post surgery the regression in the end diastolic volume was almost linear to the severity. So both MRI and echo showed that the mild, moderate, and severe, the reverse remodeling was higher in those with moderate and severe. The change of the reverse remodeling in those patients which were classified by MRI as severe was much more than by the echo. So it is possible that the MRI identified real true severe mitral regurgitations, and probably the echo data was slightly diluted. That is why it is not that great reverse remodeling on the echo Doppler, while for mild to moderate it almost looks the same. So then there is certain other very interesting thing that happens with mitral regurgitation, and this happens with something called as mitral annular disjunction. Now this is a very classical thing that happens in mitral valve prolapse, that if I stop this particular movie and show you that at end systole, you can see that I'll put this at end systole. Yeah, at end systole, the mitral annulus has actually separated from the posterior wall, causing a disjunction here. You can see the disjunction here, as if it has completely separated out from the posterior wall. Now, this mitral annular disjunction creates lots of problems, because if you look at this disjunction, then if you take this as your annulus, then there is a lot of mitral regurgitation volume which gets trapped between the mitral annulus and the billowing leaflets, and this is something which is called as the trapped volume. And it is interesting that the MRI, since it takes the LV stroke volume by taking the LV stroke volume as its major measurements, can include the regurgitation volume of the MR jet plus this trapped volume in those billowing leaflets in mitral wall disjunction. And this is something very interesting, that you can actually measure this particular area of the blood which has crossed the mitral annulus and then trapped below the leaflets and has not actually entered the LV, but it is again a part of the volume overload of the LV. So it is interesting. So the Doppler, most of the time, the PISA method measures the regurgitation volume which has crossed the leaflet inside the LA. While when you are using a phase contrast forward flow and subtract it from the LV short axis images, you have the regurgitant volume, which is both the trapped volume below the leaflets because of the disjunction, plus the volume which has crossed the mitral wall into the left atrium. So in a CMR, if you take the short axis stack, you have got a total stroke volume. If you subtract the phase contrast, you get a total transannulary displaced volume towards the left atrium, which will be actually both the volume which is trapped below the mitral leaflet but has crossed the annulus towards the LA. It is something like atrialization of the LV plus the blood which has actually crossed the mitral leaflet. So you can actually measure this in 3 axes, reduce and remove it from the transannular volume, and you can get a MR regurgitant volume which has actually entered the left atrium. And many times when you use this, you sometimes get concurrence with the Doppler measurements of this MR volume by the PISA method. So this is how you get the MR regurgitant volume in this particular case that I was talking about, that the total transannular displacement is 48 ml. And when you subtract the prolapse volume of 16 ml, which was trapped below the wall, but it was above the annulus towards the LA, you get the volume which is actually entered the left atrium. Then there are certain other important things about the primary mitral regurgitation is that by late gadolinium enhancement, looking at the fibrosis. Now, very interestingly, the patients with mitral wall prolapse of the Barlow's variety have got much more fibrosis than the non-MVP mitral regurgitation. And that puts them at a higher risk of arrhythmias. So generally in a severe MR, you almost have 34% patients with having a very high level of late gadolinium enhancement in the patients with myxomatous mitral wall degeneration and mitral wall prolapse. And this can be in the mid wall, it can be at the posterior mitral, posterior wall, especially where there is a tug on the papillary muscle, that you get this fibrosis. And this you don't get in MVP, putting the patients with myxomatous wall degeneration at higher risk of arrhythmias. So the thing is, that's the way to look at the fibrosis or the extracellular volume expansion in these patients. And this extracellular volume expansion is not only in the myxomatous MVP, but even in non-MVP MR, it can occur. And this is another biomarker which now the researchers are identifying, which can give you a prognosis, a very important prognostic factor. So if you look at these patients for the event-free survival on the y-axis and the follow-up on the x-axis, and if I show you this particular patient with its regurgitation fraction of 30 to 50%, which is a moderate MR, and an extracellular volume measured by the late gadolinium enhancement of less than 30%, which is not very high, they have much better event-free survival than a patient who has got the same amount of mitral regurgitation, the same amount of mitral regurgitation fraction, however, a higher level of extracellular volume because of the extracellular expansion, because of interstitial fibrosis or replacement fibrosis. Now, these patients, despite having the same amount of mitral regurgitation, which you would have otherwise classified them as moderate, have a much worse event-free survival. So the ECV can be looked upon as a biomarker to send the patient for early surgery. And that is another advantage of looking at the LV ultrastructural changes in mitral regurgitation. Now, the same thing you can look for the aortic regurgitation. Now, this is a lady who has undergone a wall-sparing Bental for a dissection, and this is her aortic regurgitation on echocardiography. In the aortic regurgitation, as I told you, for the outflow regurgitation, it is very simple. You just need a phase contrast image there, which gives you both forward flow and backward flow, and it also gives you regurgitation volume and regurgitation fraction. It is so simple. And then you can have internal quality checkup for your aortic regurgitation by getting your LV volumetric data. And from that LV volumetric data, you can subtract either the PA flow, or you can take the PA phase contrast flow and subtract it from the aortic forward flow and again get the aortic regurgitation, provided you don't have any right-sided valvular lesions. So you have got two other ways to have an internal quality check. And this is the same lady who has got this wall sparing Bental. She has got aortic regurgitation, as you can see on this in-plane SSFP images. And then this is her phase contrast images, which show a aortic forward flow of 109 ml, regurgitant volume of 33 ml, both measured in the same phase contrast quantitative measurements. And then you get a regurgitation fraction of 30%. Now, this becomes a little difficult when the aortic root keeps on dilating, because then that introduces error. So also you have this patient with his pulmonary forward flow, which is 76 ml. You can subtract this 76 ml from the aortic forward flow, which was 109 ml. And you can get, provided you don't have any pulmonary regurgitation, and you get a aortic regurgitation volume 33 ml, which is very close to one, which we measured by the aortic phase contrast image. So you have got a internal quality control telling you that your measurements are more near to reality. And then there is a way to look at the diastolic flow reversal in the descending thoracic aorta. Now in this patient, you can look at the diastolic flow reversal in the descending thoracic aorta, and then you will know that there is actually a dissection flap there, and there is only true lumen which is having that black colored flow which is going towards the limbs, and the reversal in the diastole which is white, while the rest of is the lumen which is the false lumen. And then that you can quantify to get the holodiastolic flow reversal, telling you that the AR is severe. And then the same patient, if you look at the color Doppler at the mitral wall, there is a mitral regurgitation, and the MRI has got a way to differentiate the regurgitant volumes of aortic also and the mitral also. So for the same patient, what one can do is that you have got an AR also and MR also. What you can do is that you have a phase contrast image across the aortic root, get your quantification there, take the LV short axis stack, get your total LV stroke volume, and from this LV total stroke volume, if you subtract the aortic forward flow, what you remain is the mitral regurgitation. However, if you want to know the mitral regurgitation fraction, then there is a little different in measurement. What you now need is that you have already got the mitral regurgitation volume. You divide it by the total LV stroke volume minus the AR regurgitation volume. Okay, because this is the only blood volume which has not crossed the mitral annulus. Because whatever has got forward subtracted by the AR is the only thing which is going to return back from the right heart across the mitral annulus along with the mitral regurgitation volume. So the denominator changes from LV stroke volume to LV stroke volume minus the AR regurgitation volume. So whenever you have got the combination of regurgitation, the MR can sort it out very well. Then, so this is how this patient has got his LV total stroke volume of 124 ml, and you subtract the aortic forward flow, which was 109 by your phase contrast image, you are remaining with 15 ml. That's the only blood which has gone into the ALA. And we want to reduce the regurgitation fraction. The 15 ml is at numerator and denominator is LV total stroke volume minus the AR regurgitation volume, which was total was 91, and you get 16% of MR, which is very, very mild MR. So ladies and gentlemen, if you have got combinations of lesion like TR and PR or MR and AR, then you can use this combination of LV volumetric data or RV volumetric data and the phase contrast data across the aorta and pulmonary artery, and can sort it out, the AR, MR, TR, and PR, looking at each wall separately. And that is something which is unique to MRI. The suggested cutoff are slightly different than what the suggested cutoff for the regurgitation fractions are there in the echo literature. So for the AR, the echo literature, 50% regurgitation fraction is the severe AR. However, for the MRI, 35% is suggested as severe. So also for the MR, instead of 50%, which is in the echo literature, 40% is suggested by the MRI literature. And for secondary TRs, echo literature is 50%, which is brought down to 30% from the natural history studies by the MRIs. Then the stenosis quantification is slightly different. Now remember, stenotic valves, the stenotic jets, the gradients change very fast, and Doppler is supreme there. But MRI has got some trick up its sleeve, and what you can do is, now like this patient who is actually the HCM but also has got a rheumatic mitral valve disease. Now in these particular patients, you can see that there is a high velocity flow across the mitral stenosis, which centrally is laminar, and it's showing some dephasing around the jet. You can plan your imaging slices exactly at the mouth of this mitral stenosis. You can have multiple short axis stacked there, which you can check in two orthogonal planes that you are perfectly perpendicular to the mitral orifice or not. And the calcium anyway gives you a beautiful black background because of no magnetic activity, and you can actually planimeter the mitral stenosis so well. So actually planimetry is the better way to go for measuring mitral stenosis by having good thin slices, rather than planning any phase contrast across the mitral annulus, because as you know that it is a dynamic annulus which just moves in and out of your imaging plane, and obviously these are very high velocity gradients changing very rapidly, which is very difficult currently by the phase contrast actually to quantify. But this for stenotic lesions, planimetry is a great way to go. The same thing is true for aortic stenosis. These jets are also very fast. They change the velocity very quickly. You may miss them in your phase contrast images because most of the phase contrast sequences will not have the amount of time resolution that you need, which in Doppler is very high and very high. So, but the thing is, you can always planimeter in say of apical long axis view or 5-chamber view, and so also in a coronal section, you can always plan your imaging planes which go exactly through the tip of this open aortic stenosis leaflet, and can get a stack of images there and can actually planimeter the aortic valve area. Then there are certain other things that the MRI can look into, and this is something like the native T1 values. Now, as the native T1 values go on increasing, the heart failure hospitalization and the cardiac death events in severe aortic stenosis go on increasing. And this has been shown interestingly by this paper in JACC, for that every 20 millisecond increase in your T1 values, there is a 28% increase in mortality or heart failure hospitalization. The same thing you can use it for looking at both the T1 values and the extracellular volume and the replacement fibrosis. And elegantly in this study by Chin et al. Has shown that the all-cause mortality is directly related to it. When your extracellular volume is within normal limit and you don't have any replacement fibrosis, the all-cause mortality in aortic stenosis is very, very less. The moment your extracellular volume, there is an expansion, but still you don't have a replacement fibrosis, it still jumps to 36 per 1,000 patient years. The moment you have got both, you have got an extracellular volume expansion and also replacement fibrosis, then the mortality suddenly jumps to very high, around 71 per 1,000 patient years. So looking at both the extracellular volume expansion and also looking at the replacement fibrosis is a way to further risk classify these patients. And this is very interestingly, and it comes in very handy when you are following up the patients of severe aortic stenosis on echocardiography and your global longitudinal strain starts falling. If it reaches somewhere around 16%, I think you can have a role of MRI look at their extracellular volume and look at the late gadolinium enhancement, and it is positive, there is probably no point in waiting for these patients to become symptomatic and you can straight away send them for aortic wall regurgitation. This is still not in the guidelines, but this is what the experts in the field are suggesting, that in asymptomatic severe aortic stenosis, when on the echo the EF is still above 55%, patient is asymptomatic, the global longitudinal strain is dropping, MRIs does have a role to look at the extracellular volume expansion and replacement fibrosis to send these patients early for AVR. And so also the MRI can come handy in asymptomatic severe aortic stenosis, in that if you start having the replacement fibrosis, it is reversible. So even after aortic wall replacement, you don't have reversibility in this particular late gadolinium enhancement. You can have reduction in the LV mass, you can have reduction in the extracellular volume, but you have no change in the replacement fibrosis. So probably the MRI can come up with a threshold at which you will be able to send the asymptomatic severe aortic stenosis patient for surgery or also for TAVR. So also you can, there are certain pitfalls here that you have to image at the vena contracta, which is sometimes very difficult. These jets change their velocity very fast. So many times your phase contrast images, because of their low time resolution, can miss those peak velocities, while Doppler has got a very high frame rates. So I think still the Doppler is supreme in getting those peak velocity jets. But as I told you that you can actually planimeter the aortic wall area very well by having your proper cuts at the peak of these doming leaflets. Secondly, so and those can be still very handy in measuring the stenotic lesions. Then this direct planimetry is very useful for both aortic stenosis and pulmonary stenosis, and also for mitral stenosis and tricuspid stenosis. So I would say for stenotic lesions, go for direct planimetry on MRI, because there are innumerable planes which you can exactly position at the opening orifice. While for the regurgitation, go for quantification, because there the MRI has got a beautiful reproducibility and great amount of accuracy. And when you have got multiple stenotic and regurgitation lesions, then MRI can come very handy. It can add a great qualitative and quantitative data to the basic echo and Doppler data. And especially when you have got multiple valve stenotic and regurgitation lesion, which is actually not a very rarity in our Indian patients, where they got rheumatic MS, they have TR also, they have some AS also, they start developing some PR, PH, RV dysfunction, so on and so forth. They're a combination of an echo Doppler data, and on top of that, devising your MRI study can give you a great information. And there actually they can the echo Doppler data and the MRI data can act tremendous complementary. And this is also true in this complementary role is also true for degenerative aortic stenosis, which now we are seeing at an epidemic proportion, that that this particular echo Doppler data vis-a-vis perfectly timed MRI and perfectly done MRI study can give the patient a lot of value addition for decision of aortic wall replacement. So there are certain unique capabilities of MRI. It has got an added value to the echo. It has got a very reproducible regurgitation volume and regurgitation fraction. It can tell you about the myocardial fibrosis, extracellular volume expansion. It gives you unrestricted imaging planes for planimetering the stenotic lesions. It can give you a lot of surrounding anatomy. Then there are certain strains of the MRI, like it can give you a very high signal to noise ratio. So you can have a reproducible volume and mass quantification in serial studies. Then there are certain strains of the PC imaging, especially when you don't have turbulent flow. It can give you, especially across the outflows, the aortic and pulmonary outflows, not so good across the aortic, say mitral or tricuspid, flows. But at least at the LV outflows and pulmonary outflow, you get a very reproducible data by the phase contrast imaging, and also you can get the direct quantification there, and that is a strength there. There are certain CMR weaknesses that you need a very good breath holding in heart failure patients. Then the quality can deteriorate when you've got frequent arrhythmias, atrial fibrillations with irregular rate. Then there are certain through plane motions can be challenging, especially the through plane imaging for a very dilated eccentric aorta with lot of swirling in it to get a good phase contrast signal. So also for the PAs. Then certain sternal wires and prosthetic wall give you susceptibility artifacts. Then the phase contrast has a low temporal resolution as compared to the Doppler. So at the highly stenotic lesions or tricuspid regurgitations, probably it falls short or inferior to the Doppler value, but it is always complementary. So whatever Doppler data you have, you always get some complementary data from the MRI. It underestimates peak velocity, especially when there are very high velocity jets, which are better measured by the Doppler. But many times it can also happen that you may not be able to align your Doppler well by transthoracic or a transesophageal echo across a very eccentric PR or very eccentric aortic stenosis. That can also happen. The spatial resolution for and some partial volume effects. Then whenever there is a turbulence, you can have some intravoxel dephasing that can introduce errors in your flow measurements. And for mitral and tricuspid region, the phase contrast quantification is not that great, but you can always fall back upon the anatomical imaging there. The diastolic function assessment is very advanced in the echo Doppler, which is still in very infancy in the cardiac MRI. So when CMR, I would say in the regurgitation lesions, if there are bad eccentric jets, there are multiple jets, then the echo Doppler has got lots of problems, especially paravalvular jets across the prosthesis. Then if you want a very serial, strict follow-up of regurgitation volume and regurgitation fraction, especially for the studies designed for certain studies which are research studies, then if you want LV as ultra-structural changes when you are following up the patients of regurgitation, especially for the right-sided regurgitation lesions, CMR is great. Multivalvular lesions, you can separate it out the regurgitation volumes and fractions, especially when you have got a combination of left and right, and especially when you have got a very suboptimal echo window and the patient have got inability to do a transesophageal echo. And then in case of stenotic lesions, it may not be that great to look at the gradients, but it is good to look at the anatomy for bicuspid aortic wall or actually planimeter the aortic stenosis. And when there is a very difficulty in aligning the ASJ even on the Doppler, then especially looking at the outside the heart, like ascending aorta dilatation, subvalvular imaging for the dynamic LVOTO, when you have got mixed stenosis and regurgitation lesions, and you want to also follow the LV ultrastructural changes like T1 values and LG and so on and so forth. And this is something which will be a game changer, and this is the 4D flow, and we know that it is already the technologies there under rigorous clinical assessment, and this can make our life little simpler, especially in multi-valvular lesions. But still you will have to acquire very high frame rates in this, and the 3D data acquisition also should be fast in less breath hold. But that's the future, and I think the science is always breaking the boundaries, and I think this is something to look forward to for the evaluation of valvular heart disease. Thank you.
Thank you very much, sir. That was a great talk. With your vast experience in echocardiography and NCMR, we really got a very complete and picture, which is definitely probably will give us insight and be more meticulous in imaging. To add with this, we have all the esteemed faculties from renowned institute. May I invite Dr. Rajesh Kannan on screen dais from Amrita Institute of Medical Sciences. We have Dr. Vimal Raj sir from Narayan Hrudyalaya and Dr. Johan Christopher from Care Hospital. Welcome, sir. And Dr. Ashita Barthur from Jaideva Hospital is also with us, and she would probably be moderating the session and asking questions to all the esteemed faculties. Thank you. Ashita, over to you.
I think your mic, you'll have to turn it on.
Yes, yes.
Hi, everyone. Yeah, thank you very much for the talk, sir. It was really good and really informative and very lucid. So a couple of questions to start with to the panelists is, so how often do we get valvular heart lesions as a referral for cardiac MRI? This is to all the panelists. So the audience get an idea as to how often we do cardiac MRI for valvular lesions.
Shall I start with this? Yeah, I think it is greatly underutilized. I think it is greatly underutilized. That is because obviously the echo Doppler had made great strides in the measurement, in the quantification, and also the transesophageal gives exquisite images. But there is a time when you are on the threshold of surgery. There is a time when you actually need a very strong quantitative data, and I think there where the MRI can do a justice to the patient. And so that is why I think the echocardiographers should have a lot of insight into the cardiac MRI so that they can do the cardiac MRI, quantitative cardiac MRI for valvular heart disease at a precise time in the follow-up of the patient, because you get a good quantitative reproducible data from which the decisions about the surgical interventions become much more easier.
Yeah, just to add on, I think, sir, an excellent lecture by Dr. Nitin, as always, very, very precise and quantitative. And it really, shows the important dimension and the great dimension that complementary imaging has to offer a patient and a clinician, wherein it is not two things giving you different informations or clashing, but complementary imaging. And he really, I think what was most important in the talk for all of us was when to do and when not to do. I think what are the strengths and what are the weaknesses. I think two areas as a cardiologist and clinician that I really use MR. One is in difficult to image valves on echo. You have window problems, you have alignment problems, eccentric jects, which you already mentioned, highly calcified lesions, mitral valve panimetry is not happening. That is where you interpose an MR in this situation. That is one area. The second area is when you're at the threshold of surgery, difficult patient due to various reasons. You have the echo parameters, you're a little worried, there is LV dysfunction on the anvil, and you want to take a call to cross the threshold, do the surgery, do the TAVR. So MR gives you just that additional referee, I call it the third umpire, and it just puts you across the finish line comfortably. And the last area is again, which sir has also mentioned, is when you're tracking a patient. When you're tracking a patient along his natural history, you have a patient with either a severe AS, you have a patient with severe MR, not symptomatic. The echo values are just near there. You're not crossed the finish line. You feel medical management is a worthy a solution for this patient. Again, MR comes in. And it's such a good tracker, as sir said again, because it's so good with its reproducibility, its inter-observer reproducibility, its time reproducibility. And we do know that the regurgitant fractions are much better than regurgitant volumes, much better than some of the regurgitant volumes you get on echo. In fact, regurgitation is a great area where MR gets to play. And when you add on the LV structural the data, it becomes very easy and robust to tell the patient, no, we need to be on medical management. Surgery is just not ready, and we'll come back after 6 months. It gives a lot of strength to the clinician to tell that patient, to turn away the patient from the surgeon. I think that I think the MRI gives you that huge additional information. Just one last observation. I have a lot of difficulty in hypertrophic obstructive cardiomyopathy where calculation of that peak is just not what the echo gives you. In fact, I do a lot of echo and I just don't even bother actually on MR to calculate the peak in terms of an LVOT gradient, because echo is just so good. And sir also showed that anybody's experience with this particular area, especially when there is a variable dynamic gradient.
Yeah, from my experience in our institute, Amrita Institute of Medical Science, Kochi, we do lot of congenital cases where our main indication in valvular heart disease is to assess the pulmonary regurgitation and the RV volume and the function in post tetralogy of Fallot. Now, where the people need regular follow up, and you need some gold standard to quantify the RV volume as well as the PR. PR volume and the PR fractions, where the MRI plays a major role. So, in that definitely MRI plays a major role, where we can not only quantify the PR, even we can quantify the RPA regurgitation versus LPA. So that also is possible. Of course, we can assess the scarring, all those things. So other than that, in adult cases, the referrals were very few. So maybe once in 2 months or once in 3 months. Whereas the congenital, at least we do 1 or 2 per week. So because that is the major indication. And as Dr. Zohan told, for the LVOT obstruction in HOCM, even we also found that it is not very accurate as compared to the echo.
I think everybody has mentioned most of the things that I would have said. Just as a final summary, I think what we are finding over the period of last couple of years is the utility of cardiac MR for assessment of valvular heart disease is increasing. Specifically, we are looking at cases who have poor LV function and to assess the true fraction of the regurgitation in these patients. That has been combined with assessment of the LV at the same time. So both LV morphology and the regurgitation has been something which we have been using more and more. And as Dr. Rajesh said, PR and RV volumes in post ICR is something very, very frequently done in a. Johan, going to the case of HCM, this has been always a big problem, I think, and MR has always had this issue. We all know about it. We've all learned about it. I was listening to one of the dons of MR, and they basically turned around and said, see, perhaps the gradient that echo calculates is not the same thing that MRI is going to calculate. So rather than trying to convert the peak velocity by 4V square into a gradient value, what we tend to do is we tend to just measure the peak velocity and say at LVOT or wherever that degree of obstruction is, to say the peak velocity is X, Y, or Z, and use that as a follow-up tool if we are going to be using them in terms of seeing whether it is increasing or going down as follow-ups. But as you said, absolutely, invariably, MR will underestimate if you are using the gradient in comparison to echocardiography. But in HCM, the other thing which we've suddenly started seeing is the decision between alcohol septal ablation and surgical correction. MRI has started playing a significant role, because if we start to show that there is a good amount of mitral regurgitation and it's into the severe category, our surgeons prefer to take them in for surgical corrections rather than doing alcohol septal ablation. So that has become another indication for us to start using MRI in patients with valvular heart disease.
Thank you. So at our institute too, we don't measure the velocity, or give the gradient with respect to MRI by measuring the velocity. But we do mention if there is a gradient by just looking at the flow disturbance. So I think that's something that we could mention in the report, and the gradient could be calculated by echo, and the patient followed up as such. All right, so there's another question from the audience. It's about quantification and the presence of shunts, the valve regurgitation quantification, the presence of shunts. So probably Dr. Vimal and Dr. Rajesh, you could take this, these two questions.
Yeah, one is regarding the shunt. So whether when there is a say, I think they are talking about the whether left to right shunt, say like VSD or ASD with the say pulmonary regurgitation. One is if you are taking the PC at the level of the MPA, if the MPA is good without dilatation, you are directly measuring the forward volume and reverse volume, and it doesn't affect the presence or absence of any other valvular disease or any other shunt lesions. It is very straightforward. Okay, only if you are now using the RV stroke volume versus LV stroke volume, there only this the shunt flow will come into the picture. Whereas in the mathematic formula, if you are directly taking, for example, an AR or a PR, if you are directly taking at the level of the iota or MPA, and there is no confusion, further confusion regarding this, so it will works even in the presence of a shunt lesion.
I think the important point here when you have a shunt lesion, as Dr. Rajesh said, you have to heavily rely on your phase contrast images. And what is important is when you have a straightforward jet, it's easy. But if you do not really have, for example, if you're trying to quantify mitral regurgitation rather than a pulmonary regurgitation, PR or AR becomes easier because you can put a nice region of interest of flow in the aorta and pulmonary artery. If you're trying to do an MR regurgitation jet, there the problem becomes is that the jet is very wide and the region of interest that you're going to put is not going to be in an oval shape as well as possible. So it is very important, as Dr. Burkule said, that you need to get perpendicular images. So what we tend to do is we tend to first do in-plane flow to actually see the jet in MR. From the in-plane flow, then we plan a through-plane flow. That way, we are very confident that we are getting a good area that we can see and quantify the flow. So PC is better in such scenarios, but it's important to get good PC images as well.
Yeah, I think I also agree with the Vimal. One important thing is you have to take at multiple plane. See, one of the problem is many times you will do the post processing after the you taking out the patient. Okay, so it's because especially for this regurgitant calculation, even breath hold sequences are very good. So as compared to the congenital heart disease shunt lesions, where we usually prefer a free breathing sequence, so that means the scan time is much higher. Whereas if you are doing a breath hold sequences where it is going to take only about 15 seconds, so you try to take at least even if you want to quantify AR, there are many studies which shown that the AR value, aortic regurgitation value will be different whether if you are depends on whether you are taking at the level of the ascending aorta or taking at the sinotubular junction or at the aortic root. So depending on the size of the aorta, so it's very important. So what you can do is always try to take more than one level. Take both the at the level of the MPA bifurcation, one ST junction as well as the root of aorta. Now sometimes that will be helpful, and we can see whichever value which is more closely correlating with the other internal values like right sided heart measurements. So whichever values are more correlating with that, you take that measurements as a to calculate this AR or PR.
Thank you. So the other question from one of the audience is for RV quantification, is axial stack better than short axis, or which would you prefer?
I think we use short axis, okay, and it is better to, when you're quantifying, I think it is better to be, the stack should be contiguous without any intervening gap, and especially for the RV, definitely. But I don't know what the others prefer.
In our institute, for congenital heart disease, for the post tetralogy follow-up ICR cases, we do the short axis. One main advantage in the post ICR is usually the RV wall thickness is good. Okay, so and assessing the RV in a SAT axis is very good. Whereas if you are looking at the some of the RV dilated cardiomyopathy cases or the ARVC cases, where the RV volume, RV wall going to be very thin and it will be grossly dilated. So and in that cases axial may be useful, especially assessing the differentiating RA from RV, where the the AV valve level assessment may be bit difficult on a SAT axis. So you can both are equally good. Only thing is the in the axial plane the major disadvantage is if the level of breath hold is not accurate, then you have a lot of error, lot more error as compared to the SAT axis.
So, Ashita, it's an interesting question, okay, and this is something a lot of people keep talking about. There are multiple reasons to do different things. If you talk about a senior versus a junior who's going to do an RV volume, juniors or newer people will always find axial cine stacks to be easier to do RV volumes, especially when you're looking at the basal slices on a short axis. You will not be able to clearly judge, especially in diastole and systole. So seniority as an experience makes a difference. Second important parameter comes in is how much time do you have? Majority of the patients, you are trying to get them in and out of your scanner. Doing another set of axial stacks will always cause more time in there. So that's why people prefer to do short axis. Important to remember is if people have a sternotomy and you have a 3 Tesla machine, short axis sternal wires will give you a lot of artifacts over the right ventricular anterior wall. You may not see that many artifacts in an axial image. So in that scenario, you may want to do axial. As a default, if I am asked, if somebody comes to us with RV cardiomyopathy as a question, we will do axial cine stacks. That is our default. We use that for doing volumes. One exception to that rule is Epstein's anomaly. Many a times when you're looking at an Epstein's anomaly, to actually quantify the functional RV cavity site, many a times the short axis images are much better than the axial cine images to actually see where the true valve is and where the RV cavity is. So in my experience, I would say 80% of the times, if you want to specifically look at RV and you don't have much experience, you would be better off doing it in an axial plane. On today's day, softwares which use artificial intelligence, softwares which do automated values are more accurate in the short axis plane to do the RV volumes compared to the axial planes. There are some newer ones which are able to do it in axial planes, but not yet available.
Right, thank you. So I guess with this, we'll end today's session. It was a really good talk, sir. And you've covered everything possible with respect to valvular heart disease. So I thank all the speaker, the panelists, and all the attendees for this wonderful session. Thank you.